Hello everyone, and welcome to the fourth and final webinar on access to personal health records. I'm Henry Scowcroft, I'm a patient editor here at the BMJ. Thank you very much for joining us. Over the last 3 weeks, we've been exploring the barriers and challenges in the way of allowing citizens, patients, all of us to have access to our own personal healthcare records. We've covered ethics, we've covered the cultural and professional issues, and we've considered the concerns over inequalities and how to minimize these. If you missed these discussions, they're all available on the BMJ's YouTube channel, which I'll post a link in the chat later. Today, for the final webinar in the series, we'll be looking at perhaps the trickiest of all of these issues, which is the technical, legal and governance issues to be solved in allowing people full, rapid access to all their personal health records. We have a fantastic panel to discuss this, who I'll introduce shortly. But to kick off tonight's discussion, I'm delighted to welcome Maria Hägglund. Maria is an associate professor in health informatics and a senior lecturer in implementation science at Uppsala MedTech Science and Innovation Center. In 2019, she was a keen open notes scholar and a visiting lecturer on medicine at Harvard Medical School. As a member of the DOME Research Consortium, she has explored the impact of patients' access to their health records, including their notes, through the Swedish National Patient Portal, the National Swedish Patient Portal. She leads several national and international research projects on this topic. Maria, over to you.
Thank you, Henry. Let's see if I can start sharing my slides and the right ones. And thank you for inviting me. It's a great pleasure to be here. This is one of my favorite topics to talk about, so I will try my very best to stick to the 10 minutes I've been allocated, but please interrupt me if I start to go too long. So I'm an associate professor in health informatics. I have a joint position between Uppsala University and Uppsala University Hospital, and I do a lot of research, as Henry said, on patients' access to their health records. And I thought I'd start today with a bit of an international overview quite rapidly, so I won't go into details. And where do you start when you're asked to do that? Of course, you start where you're at. So I'm going to start in Sweden, and I'm going to give you an example of what happened when we started to implement patients' access to their medical records in Sweden. And what I'm presenting here is research that comes from the DOME Research Consortium, a Swedish collaboration of researchers who've been studying this phenomenon since it started. So how did it start? How did patients gain access to their medical records? Well, actually, it was already in 1997. We did the first pilot. It was in Uppsala, the region where I live and work. And it was one general practitioner who decided that he wanted to give his 500 patients access to their medical records online. And in collaboration with the IT department at the region, they set up a pilot project, and it was really successful. He loved it and his patients loved it. But so the region said, well, let's try it on a more broad scale. But then the data inspection board at the time decided to intervene and say, no, you can't do this, it's illegal. So the project was shut down. And then, of course, it was a bit of debate and discussion. Why shouldn't patients be allowed? I mean, we have proved that it technically works, so why can't we give patients access to their medical records? And in 2008, 6 years later, we had the new Patient Data Act in place. So we needed a change in the legislation. And the work started up again in Region Uppsala, now part of an EU project. And in 2012, all patients in Uppsala gained online access to their medical records. And I know that it was 2012 because I was on vacation in Thailand, which feels even more exotic today than it did then. And I had to go up to the hotel room, leave the pool and log in to the internet and access my medical records. And of course, tweet about it because otherwise it hasn't happened. But this was then a very local solution. It was only patients in Region Uppsala, and it was directly connected to the electronic health record systems that was in use in that region. But in parallel, work was going on a national level to actually create more of an infrastructure for being able to share data between regions in Sweden. And in 2014, this local Uppsala solution was moved to the National Health Information Exchange platform. And I'm not gonna explain that in detail, even though perhaps with considering the topic of today, it would have been good, but the platform, in a sense, it keeps tracks of in which of all the different electronic health record systems used throughout Sweden, data about a specific patient is stored. And when the patient logs in, data is gathered from all these different systems. So data is not sort of uploaded to a national repository. It's kept in the local systems. And then when you log in online, it's shared with you. And we also had the first version of a national regulatory framework for the individual's access to their health data. And this had a lot of room for choice from the healthcare providers. So each region decided to give access to certain information, and it became quite a fragmented view. But at least it was possible for more regions to connect. So from 2014 to 2018, all of the 21 regions we have in Sweden connected and started giving patients access to their medical records. And as you can see, this little map of Sweden is now completely blue, which means that all regions actually give patients access to their medical records through the same solution. And this is just very briefly what it looks like. So this is what it looks like when I log in. So I have access to my notes, my medications, etc. And in total, over 5.2 million individuals have logged in at least once to access their records, which is more than 50% of the Swedish population. So it's quite frequently used, actually. And you have access to more or less everything from both primary care, secondary care or specialist care. And in Uppsala, you also have access to your dentist's records, which has at least made me floss more. And you see more or less exactly what your clinicians have written in the record. Of course, Sweden is not the only country to do this. The Nordic countries are maybe a little bit unique in having these national platforms, which makes it, you have one place to log into. And we have one research project ongoing at the moment, which is called Nord eHealth, where we're doing comparative studies between Sweden, Norway, Finland, and Estonia, who all have their own national patient portals, but with slightly different designs, slightly different infrastructure, and different functionality. So we're really looking forward to be able to share over the next 3 years a bit of what we learned by comparing these. Of course, Denmark and Iceland also has their own national patient portals. They are unfortunately not part of this particular project. Across Europe, things are also happening, but with other challenges, I would say, and other types of solutions, often more local. So a certain hospital will share through their patient portal, etc. Across the Atlantic, we have the USA, of course, and there the Open Notes research group has been very much pushing the implementation of patients' online access to their records. And this map, as you see, is a little bit old. It's even much more, many more patients now have access to their medical records and notes online. And in fact, in April this year, new legislation came into force, which makes it mandatory for healthcare providers to share data with patients. And there are even financial incentives for them to do so. And by financial incentives, I mean heavy fines if they do not comply with these rules. So that has caused quite a bit of a stir in the US, and the healthcare sector is adapting to this new regulation. Of course, Europe, and I won't have time to go into detail, but this is, of course, not a phenomenon only in Europe and the US. We have examples of this in Canada, in Australia. India has a very interesting progress in this area. Singapore, South Korea, and many more examples. So this is really a global movement. But I will try to sort of summarize a little bit of the topic of today, implementation challenges. And I wanted to do this starting from a more of a theoretical perspective. So I took this starting point in some of the theories from implementation research, the Consolidated Framework for Implementation Research, for example, and the IPARIS framework. They identify a number of dimensions or concepts that are very important in implementation. Starting with the intervention itself, the what. What is it that we're implementing? In our case, of course, patients' access to their health records. And, just trying to move myself out of the way. For example, when it comes to patients' access to the health records, things that could impact implementation is, of course, the design of the portal, usability factors. What information are you sharing? Are you sharing enough information for patients to actually want to log in? Who decides what gets shared and how is this decided? Does it require some sort of manual uploading of data? What's the access procedures like for patients? This is something that has been quite challenging in Sweden. We have a very complex sort of login procedure for many patients. And of course, standardization, interoperability issues. How do you, can you have a sort of, as we do in Sweden, a national patient portal, for example, connecting many different systems. Of course, the target group, really important. And I actually extended it a little bit, target group, people involved. And of course, one of the implementation challenges is reaching all patients. We still have patient groups who are not maybe very literate when it comes to using e-health, vulnerable groups. Certain disease. I mean, we are, for example, still struggling with how to handle psychiatric records. Should they be shared and how? And of course, we've had, I think in most contexts where this has been implemented, there has been some level of resistance from healthcare professionals. Not from all healthcare professionals, many are also championing this. The context is, of course, really important, and this will look different in different countries. So the infrastructure you have in place, the incentives, both perhaps financial and others, laws and regulations are, of course, highly important, things that we want to discuss at this seminar. But also the internal culture in a healthcare organization. How ready are people? And is this something that is sort of supported by the leadership in an organization? What kind of learning culture do you have? Do you have a culture of reprimand within the, if something goes wrong? Are people very worried that errors in the record will be exposed, etc.? And of course, governance issues. Who makes sure that this is done? And last but not least, the implementation strategy. How do we implement the intervention? What resources do we have in place? How do we educate people to start using this new intervention? What's the support for leadership like? And last but not least, champions have proven to be very, very important. And I know for sure that I can count maybe 4 or 5 people in Region Uppsala. Without those people, we wouldn't have, no patients in Sweden would have access to their records yet today. So the local champions can be extremely important. And just to give an example of some of the differences or the challenges in different contexts, we can just say, you know, just the fact that in some countries we have a national patient portal that connects to different EHR systems will give you different implementation challenges than if you have local patient portals connected to each healthcare provider's EHR system, as you do, for example, often in the US. Kaiser Permanente will have one patient portal connected to their electronic health records, etc. And then, of course, these types of differences will impact on all these important questions around who has access, who decides, when do you gain access, and how, and who controls access. And with that, I think I'm out of time, and I look forward to continuing discussing this over the next 45 minutes.
Thank you so much, Maria. That was a fantastic overview and a really good setup for the discussion. Before I introduce the rest of the panel, just a little bit of housekeeping. There's a chat function. Many of you are already using it. Please use that to discuss and interact with each other. And there's a little drop-down box on there that says, should be set to everyone so that everyone can see your message. You can pose questions to each other through that if you need to. If you want to pose a question to the panel, there's a separate Q&A box, and that will really help us keep track of everything and respond to your questions and spot them. Otherwise, they can get a bit lost in the chat. And if you are on Twitter and want to tweet along to this webinar, please use the hashtag #BMJ Records Access. With that housekeeping out the way, I would like to introduce our panel. Kaiser Immonen is Director of Policy at the European Patients Forum, EPF. Kaiser leads the EPF's policy team and focusing on strategic planning, policy analysis, and building relationships with international organizations. Since 2016, she's also been co-chair of the European Medicines Agency's Patients and Consumers Working Party. She's a patient representative on the EMA COVID-19 Task Force, sits on the OECD's Healthcare Quality and Outcomes Working Party, and is a member of BMJ's patient panel. John Farrington works in strategy and discovery and as research program director for Shared Care Records for the Shared Care Records program at NHSX. He has a background in applied computer science and has worked in health informatics since 1988. He's interested in all aspects of record and care plan sharing. Is currently working on research into distributed records and also the International Patient Summary. And Dr. Zoe Warwick is a consultant in sexual health and HIV medicine at University Hospitals Plymouth. Zoe started to implement patient-held records within their HIV service in 2013, and more recently has expanded their use into sexual health. With those intros out the way, I think, Zoe, let's come to you first. Maria talked about the need for local champions and for local engagement and enthusiasm. Would you mind sharing a little bit about your story of implementing patient-held records in Plymouth and how you see your role as the sort of local champion for all that?
Yeah, so we tried to implement an integrated patient-held record back in 2013, and at the time when we wanted to do that, it was very apparent locally that it wasn't a priority, it wasn't on the trust's agenda. Fortunately, within sexual health and HIV, we are slightly separate to the main hospital trust, which gave us the freedom to start to push for our own patients to have access to this. And when we tried to do it, there were lots of barriers. So you come up against barriers. If it's not a priority for the trust or the organization, then it's a no. Resources are limited, funding isn't there. If there isn't, at the time, our patients weren't banging down the door asking for this, so there wasn't a lot of support we could get through the sort of advocacy support. So I think having individuals within departments, within trusts, within organizations who feel very strongly that this is the right thing for their patients, and also to improve the quality of healthcare that's delivered, you need somebody who every time they get a no wants to keep coming back and saying, okay, it's a no here, but how about now, or how about with this, or let's ask somebody different. And you need to make sure that by doing that, you're speaking on behalf of the patients that you care for and acting in a way as an advocate for them. Because you need to have trust. The patients need to engage with the system that you implement. And what we found is if the patients don't trust the reasons for the implementation or how, and if it doesn't function well when it's first implemented, then you lose their enthusiasm. So having somebody who wants to make sure it's done and then make sure it's done with patient engagement and the time to do that, I think is really important. Yeah.
And we'll come back to that, the topic of patient engagement in this a bit later on. But could you talk a little bit about some of the other aspects that Maria touched on as well, about the need for standards and interoperability, and perhaps the paradox between local engagement and the need for sort of technical standards, etc.
Yeah, and I think that's the difficulty. So yes, you may get these systems implemented because you've got local champions, but what that means is that regionally or locally, you have different individuals trying to implement systems, and if those systems are different to the neighbouring trust or the neighbouring local authorities, or they're not integrated with primary care, then all of the main advantages and the utility and the benefits that these systems can bring to patients are often undermined somewhat, because there isn't engagement across the system from clinicians, and patients don't find these systems useful when they access care in other settings.
Thanks, Zoe. Maria, any reflections on that from your point of view, and how Zoe's experience maps onto any of the things you've seen in your work?
Yes, I mean, when things first started in Uppsala, for example, in Sweden, it was a very local solution. And it would have been impossible for Region Uppsala themselves to sort of spread this across Sweden if it hadn't been for, we have all of the regions together own an organization which runs the sort of Swedish e-health infrastructure. And if they hadn't been there to take on the role of actually setting up the interoperability platform, I don't think we would have had a national solution today. So it does require something more. The local, the champions can run the local solutions, but then you maybe need champions on a different level who say, look, we need to have this infrastructure in place and have the power and resources to get that in place. And that might require different people from the local champions. So you might need champions on different levels to get the full.
And I guess there's also the champions outside the healthcare system as well. And Kaiser, I suspect that from the patient perspective, and particularly in your work, there's been quite a lot from the EPF to think about this. Is there anything that you want to bring to this conversation about advocacy and championship from the EPF perspective?
Yeah, thanks. And thanks, Maria, for the presentation. It was really nice to look at the Swedish experience as an example. Of course, I come from an organization that operates at the European level, and we engage with European health policy and initiatives. So I think when we talk about technical aspects and governance, the EU has something to offer here, and of course with the recognition that things are global and the EU is only one part of the world. But when we talk about standards and coming up with general principles on how things should be done, I think there's some value in that. And as you also pointed out, Zoe, innovation and things happen bottom up often, but then the top down governance can be either a hampering factor or it can be an enabling factor. So it's important to get that right. And we have things at European level like the General Data Protection Regulation, which has to some extent a bad rap for being a hampering factor for sharing health data across borders, for example. But I believe that the existence of this GDPR is actually a very good thing, because it creates a set of rights for European citizens, and it also creates trust. People in Europe know that we have this regulation that is to some extent stricter on protecting citizens and their rights than in some other parts of the world. And I think that's a trust factor. But of course, there's fragmentation in how it's implemented. There are some other interesting policy initiatives that are in the pipeline, and maybe we can come back to those, but I think there is something promising happening right now in the European space on this.
Thank you, Kaiser. So John, we've been talking about sort of local activism from the NHS X point of view. How does that sort of sit in your sort of your approach to all of this? And if you will, if we can sort of then sort of start talking about the standards that are out there that can maybe sort of help local enthusiasm gain purchase.
Yeah. Okay. Well, there's a huge amount of standards and a lot of debate amongst those who are involved in those bodies. I'm interested in not just the standard, but the way it's implemented, because clearly the context in which information is shared is so important. And often we forget that. We just think it's about the data. It's about how it's used, who it's used by, and the environment in which they're using it. I wanted to share with the group some work that we are doing, which I think would be of relevance and interest, because in June this year, the G7 health ministers met in the UK, because the UK is the chair of the G7 this year, and they committed to exploring the use of the International Patient Standard, which is an HL7 standard to support sharing of information across country borders. Now, while it was the G7 group of countries, they did want to make sure that it was extensible much way beyond that. Now, we've got people who've been working on some time about trying to exchange international patient summaries on a cross-border system-to-system basis, but they find all sorts of challenges in technical situations, the legal context of different countries, and the way their health systems are organized. So we had the challenge of trying to think how we might address this time in a slightly different way. So the way the G7 works is that each chair country progresses actions that are agreed by the ministers. And then at the end of the year, they pass that over like a baton to the next chair. But of course, by the time the health ministers had agreed this in June, we didn't have a lot of time to do any work. So we decided we'd try and look at this through a new lens and build ourselves a little proof of concept or prototype, simply so that we could share it and have a really good debate about how this might work in practice. We also thought about the default position of what happens at the moment. So if a patient needs care in another country, generally speaking, the professional starts off by having to rely on the memory of the patient about their condition. And my memory certainly is fallible. If they've got a long-term condition, they might have taken some records with them, but they'd probably be in an unstructured or unfamiliar format. So we decided we'd try and work to get a basic structured record based on the International Patient Summary, which, as I say, is an HL standard, and place it in the patient's hands. So we moved to patient-mediated record sharing. Now, here in the UK, we've got 4 devolved administrations, and in England, we can extract the core IPS data from our GP primary care systems using a national service called GP Connect. And other countries will have other ways of creating that international patient summary. So we did it our way, but other people will do it theirs. Once extracted, we can create that IPS record. Technically, we're creating a FHIR resource. And for our proof of concept, we store that in a thing called a solid personal data store, but there are different models of that. So again, the theme was always about extensibility. We also provide the patient with a QR code, a unique QR code, which they can hold on their mobile phone or on paper. And it's at that point that the ownership of the record transfers to the patient. It's a snapshot of their record at a point in time, so we need to make sure that provenance is very clear. And we need to get agreement of our professions, and that'll be the same for all countries. But then at that point, it's for them to decide what they want to do with it. So if they're abroad and they need it, they can provide that QR code to a health professional. It's their choice. They're in control of that decision. After a short process of authentication, the professional they're talking to can use that QR code to download a view of the international patient summary from that patient's data store. And it's then for the professional to use their professional judgment to decide whether, or in fact how, to use that information. But at least it'll be in a consistent format, and we can, to some degree in our proof of concept, translate it into the language of the professional. And it's certainly better than relying on the memory of the patient or a bunch of unstructured documents. So we've developed that proof of concept over the last few months using open source components, so they're quite shareable. And we're about to present it at the end of our G7 chairpersonship, and we may pass that over to the next G7 chair, which is Germany, but we may actually continue to look at how we might use it across our 4 UK countries. And that was really the experience I wanted to share with you today, the fact that we're trying to see if we can free up the exchange of information by patient-mediated approaches.
So that's a really lovely example of some technical work that seems to be sort of trying to put this in the hands of patients directly. How does that sound to the rest of the panel? That to me sounds like a really lovely proof of concept. I guess the question is, where does it go from here? Kaiser, would you like to come in on that?
Yeah, I actually had a question to John. I'm not sure that's a really interesting proof of concept. I'm not sure if I understood it correctly. Is this system something that slots kind of onto the health record system that already exists. So it would work also with patient portals where the patient inputs data into their own health records. Because the reason I'm asking is because our community really has moved on from advocating for access to one's own health records, but also to the shared health records, so patients can also input data.
Yes. So in our proof of concept, we found a way that we could give space for a patient to add their own information about me, we call it. So alongside the structured record of the International Patient Summary, which is highly structured, there's almost a free text space for the patient to express their own personal views. So it's a kind of blend of the two. And we wanted to do that just to think, how would that work in practice? And to what degree would patients want to do that? And what degree would that cause issues for the professionals using it? So as I say, the proof of concept is a prototype. It's really just to test it out. And what might be a nice thing to do, we'll look to Henry about this, is once we've got this out in the open, we might be able to run another webinar and just do a show and tell for you all.
They'd be very, very eager to hear how this actually pans out in the wild, definitely. So yeah, be very keen to explore that at a later date, John, for sure. Zoe, Maria, anything to pick up on John's points there?
I think it's I think that the questions of standard is really important, and I know that in Sweden there was a very pragmatic approach to getting all the different EHR systems communicating or being able to upload information. But what is happening now in Sweden is also quite interesting, where focus when it comes to standardization is shifting more towards, rather than sending or sharing information in standardized sort of messages where you have to adapt to a standard. It's about standardizing the core of the electronic health record using, for example, OpenAir or other such types of standards, which could potentially facilitate exchange of data also internationally, as they are open international standards. But this is, of course, requires EHR vendors to do a lot of work to update their systems. So it's, again, this sort of, where do we start pulling how do we create incentives for them to use such open standards?
And I was going to say, I also think it depends on the reasons for designing these records. So if your reason is to share medical information across borders, that's in a unified or standardized way, that's very different to creating a patient record that facilitates engagement of the individual in their own healthcare management. And I think the design of the tool almost needs to be slightly different. So what the clinician needs from a digital tool is quite different often from what a patient or a service user might need from their record. And so it needs to be a system that talks both sides of the story, can add and subtract and discuss. So it needs to really be interactive. And I think for me, the design of that really depends on what you're trying to deliver, what the purpose is of what you're trying to do.
I'd agree entirely. I mean, the remit was, as I say, the International Patient Summary, which is just a subset, but it is a structured subset. But I think the learning is that actually doing something with a subset now may save more lives and improve health than trying to have perfection, which still takes us 10 years to reach it. As long as it's safe.
Absolutely. Well, that sort of segues fairly neatly into to another thing that I was hoping to talk about, which is more about the sort of the governance structures around all of this, and how this is all sort of made to work seamlessly together, but also particularly IT governance, something I know, Zoe, you've spoken about having, particularly in the story you told just now, just trying to get this stuff done and put together. How do we govern this stuff once it's out there? Once we've done the proof of concept and proved it, how do we get this stuff to play nicely? Zoe, do you have any thoughts on that?
Yeah, I mean, the GDPR regulations have got it all there for us in lots of ways. And I think as long as the systems that you're using have got an SLSP, and most systems that are, designed for this have that, there'll be a data protection impact assessment that organizations will need to do. And as as we've already established, technically it's possible. The security is there, and you just need in principle a single unifying piece of data that will identify the individual. Obviously, practically, most systems will use 2 or 3 data points to ensure that there aren't any errors that allow data to be sent to the wrong individual or put into the wrong record. But the frameworks are there, definitely.
Kaiser, any thoughts from you from the sort of more European, cross-European perspective in terms of governance?
Yeah, I think it's well, from my perspective, governance has to include patients and citizens. That's also a trust issue, I think, and it's also a bit of like an issue of transparency and oversight and accountability. The paradox that's a little bit similar to what you talked about with the local champions is that the higher up you go in terms of the level of governance, the more difficult it becomes to have meaningful representation of patients and citizens, particularly when it comes to shaping such hugely technical solutions that we're talking about. And there are all kinds of issues that need to be overcome. I don't have a solution for that, but at least we have patient communities working at different levels, locally, regionally, nationally, and of course, European and international level. And we try our best to show and to convince the international bodies, for example, that are working in this field, how important it is to be inclusive in the governance. And I have to say that the tech sector, the digital sector, is one where patient involvement is pretty poorly understood in my experience so far. And I think governance here cannot be really separated from issues of design, co-design, and everything that comes with making the solution. So
it's interesting to hear you say that, Kaiser, because one of the things, my experience of working with technology has been this enormous focus on user testing and UX design, which seems to be the sort of, you don't do anything without doing proper UX testing in tech. And it astonishes me to hear that in health tech, it's not there.
Yeah, because technical customer, I'm looking for the right word. The consumer technology, I think, is very customer centric. But when it comes to health, somehow the idea is not yet there.
It's fascinating. John, how have patients and patient advocacy groups been involved in the work you've been talking about with the G7 and the proof of concept?
It's fair to say, given our timescales, we've not opened the doors to them a huge amount. What we wanted to do was to produce our prototype, so we actually had something that we could show and tell, rather than talk about it in the abstract. We could say, here, how does this work for you? And we set it up so that it actually generates a QR code. I mean, it's dummy data, clearly, but a QR code, and they can hold that on their phone, and they can imagine the dialogue they might have with a professional. So once we've got it up and running, and as I say, it's about a week away from that, we are going to want to sort of show and tell with some patients and get their reaction on that.
Fantastic. Zoe, how was patient involvement embedded in the rollout of your systems in Plymouth?
Yeah, so I think there was just a comment on the last discussion. There's something about who the customer is as well. So I think depending on who the customer is, that's where who you look to help design your digital tool or your platform will depend on who the customer is. And so that's, I think, how we need to frame the conversation. So rather than healthcare organizations or government being the customer, it needs to be the patients that are, or the service users that are the customers. And then when I think if it's viewed that way, then I think there'll be more engagement with the customer, because the customer's always right. With regards to the sort of implementation that we did and user engagement, it was really, we had a cohort of patients already established, and for us, it led to a conversation, a really sort of a structured conversation with every individual patient within our cohort about what they understood about information sharing. And it was really interesting because we, certainly as healthcare professionals, I think we took it somewhat for granted as to what people understood by confidentiality and how their information was shared. And it kind of broke down into thirds, really. So about a third of people thought that all of their healthcare information was shared widely amongst healthcare professionals, so different trusts, primary care, secondary care, etc., which for us wasn't the case, working in a sexual health service. And another third felt that it was completely confidential, wasn't shared with any other healthcare organisations or individuals, and it was totally private between them and our department. And then a third of people had actually never even really given it a thought. And it was a question that they'd had asked of them, or that had come into their minds for the very first time. So for us, it was a really great process, because just by having those conversations, we really started to engage people to think about who they wanted their information sharing with, and also how involved they wanted to be in accessing and amending some of that information. So yeah, it was really quite informative.
I think that highlights a thread that has been woven through all these 4 webinars, which is this idea that just in having conversations about healthcare records, it brings up the overall quality of the conversation between doctor and patient, and perhaps even boosts health literacy. Maria, is that something that you recognise from the Swedish experience?
Yes and no. So when things first started, I think patients were not involved at all in the design or the implementation. It was more of a driven by sort of enthusiasts who wanted to see whether this would work. It was, that was very early on. But the need for involving patients has become much more obvious over time. There are some things in the design that are simply not adapted and useful. And of course, over the past, we have a 10-year anniversary coming up next year, and we have seen several versions of this patient accessible electronic health record in Sweden. So I think that that's something that the understanding of this has also evolved over time. Now I lost my thread of thought.
Don't worry. It sort of brings to one of the things that we've had some chat about in the run-up to this webinar is the idea of where the activism comes from, and the push and the pull, and we've talked about the local champions, we've talked about the top down. I was thinking back as well to your presentation about particularly the American experience, but they had a legislation change there, and the idea that changing the legislation will suddenly somehow magically open all of this stuff. There's also the issue that there can be legal barriers, as you spoke about in the early phase of the Swedish story, where the thing was shut down because it was found to be in breach. I wonder if we could spend a minute or two thinking about the legal side of this, and to what role legislation needs to play a role in driving widespread implementation of this. Actually, I think, Kaiser, can I come to you first on this one to talk about the European situation vis-a-vis legislation, etc.?
Sure. I think it can be quite influential, actually. Of course, it depends on the nature of the legislation as well, but let's go back and think about the pharmacovigilance and the patient's right to report suspected adverse drug reactions directly to the authorities rather than having to go through a health professional. Few countries were doing that. The UK and the Netherlands were those countries that probably have the longest experience in that. But then the European legislation on pharmacovigilance, when it was revised, made it mandatory in all EU member states that they had to give patients this option. And it happened. Okay, it happened gradually, but it happened. Currently, there is in preparation an initiative called the European Health Data Space. That's one of the main health priorities of the current Commission. And it's also it links into the European Commission's general priorities around digitalization, which actually is not driven at all by health. It's a much broader area, and there's a lot of internal market involved and so on. But what's interesting is that one of the explicit objectives of this is increasing patients and citizens' access to and control of their health data. And whilst we don't yet have a legislative proposal, so we don't know what form that legislation will take, it's possible that it will establish the right to portability of health data and might spur the development of specific tools to facilitate patients' access to and the portability of the data. So that's a very interesting thing that we're keeping an eye on at the moment. And actually, there is a thing called the EU's Digital Decade 2030, and one of its targets is 100%, so all of EU citizens having access to their medical records by 2030. It's quite ambitious, but yeah, it's interesting to think about if there could be a pharmacovigilance effect here.
Fascinating. Zoe, when you were setting up your system, the legal aspects of this, how did legislation and legal issues help or hinder?
So I don't think they did either, actually. I think, so obviously we have a legal requirement to share information that are kept in medical records with patients when they request it. But we don't have a legal obligation to have patient access to their records in a real-time fashion. So I think ideally what somebody who really wants to get these things implemented could really do with is having the support of that legal framework, so that I could go and say, well, my patients have a right to this and we want to deliver it, and then it's very difficult for anybody to put those barriers up, and at the minute the legal framework doesn't support that. There's no legal obligation to have a real-time access to patient records. And
sadly, even if the stuff Kaiser talked about at EU level came about, sadly that does no longer apply to the UK. John, how does legislation affect, oh sorry, Maria, did you want to come in then?
I just wanted to give one. I'm thinking, I mean, the legislation in Sweden was an obvious barrier when the project shut down.
Yes.
It was illegal. And I think that is not uncommon that this could happen. But I've also seen that when we've looked at sort of progress across Europe, that even countries in the legislation is rarely a driving force. It can take down barriers and say it's absolutely fine to give patients access. It might even say you should give patients access, but it will not drive that change. Even if the legislation says, yes, you have to give patients access, you still need the champions, you need the people doing the work. Otherwise, it's a toothless legislation. And I think we've seen that in a lot of countries, that the legislation itself does not, it can be a barrier if it makes it illegal, but it will not make the change, even if that's my...
So necessary but not sufficient, I believe is the term. John, how have, in designing the solutions you've been thinking about, have you been thinking about legal considerations? Is there anything that the legislation could have helped with?
Well, not in the example I was giving, but you made me think of something else that happened where legislation did have an important part to play. So in England, there's a thing called the summary care record, which most of the population have a very narrow one. It's a thin one. It's just about allergies and key things like that. And if people had a long-term condition, they could choose to opt in to have an enriched summary care record, but they had to have a conversation with the GP and decide that was what they wanted to do. In the first wave of the pandemic, because of the legislation that was brought in, we switched from having an opt-in to an opt-out model. And instead of having 5% of the population having what we called an enriched summary care record, we suddenly moved to 90%. Now, that had two interesting factors. The behavior of clinicians beforehand was that they tended not to look at the summary care record because generally speaking, there wasn't anything there that was of interest. Now that 9 times out of 10 there is, we've seen a huge uptake in its access. Now, I'm not saying it's the answer, but it illustrates how the legislation actually changed things around. We still gave patients the choice to opt out if they wanted to. We weren't going to remove that particular right, but the opt-out rates didn't change whatsoever. But it has saved lives and it's improved healthcare. There's no doubt about that. Now, it's only for the purpose of the pandemic legislation. So we do need to consider really seriously how we lock in some of those benefits and still protect patients' rights. So although it's not access for patients to that information, it's actually made a difference to patients' lives.
That's a fascinating story, and was that an intended consequence of this?
Well, I guess what happened is we were, I say lobbied. We were contacted by a GP who said, "Look, I think this is a really important national asset that you've got, and you just don't know how important it could be in this pandemic situation. The legislation gives you permission to do this, and I would like you to look at that." It took us 2 weeks to deal with the professional and the regulation and the technical issues. 2 weeks, things that have been taking decades beforehand, but the legislation unlocked that door. We had to protect the patient's rights. So I say we maintained the option for them to opt out. But it was generally not seen as contentious. And the challenge we have at the moment, to say, is saying, when that legislation comes to concludes, unless anything changes, we have to revert back to the old way of doing things, which seems to be a big retrograde step for both professionals and patients. But we need to have that dialogue and make sure we're supported by the legislation for it.
And Kaiser, what's the EPF view of changing opt-in to opt-out?
We don't actually have an explicit view on that yet, I would say. I'm not sure if we will, because we are really discussing a lot of these things with our community. I just wanted to comment on what Tessa said, because it's a little bit relevant to this discussion. She's said in the chat that something about the research agenda. I lost her note now, but there needs to be compelling evidence of benefit that these things work and have added value. And I would say that's actually really important also to help us as civil society, as patient communities, to advocate for a legislative change, because I do remember the discussions around pharmacovigilance. There were so many debates on, do the patients, do they even report properly? I mean, does it bring added value at all? Is it, and then a lot of research was presented saying, the Dutch experience, the UK experience works perfectly, there's no problem.
Thank you. Anyone else want to come in on the issue of changing the opt-in to opt-out? In which case, we've had some very excellent questions posed by many of you listening in, or watching, should I say. One of the ones that's come up a few times, I think, is around who's doing this well, and where might we look to for inspiration on this to chart things forward for those countries and regions, trusts and wherever that want to be moving ahead. Maria, in your sort of look across the globe of your roundup at the beginning, who are generally being seen as the countries that are really ahead of the curve, or even the systems or the best practice that exists out there?
Oh, you're putting me on the spot here, because I think it's really difficult. And of course, I'm tempted to say Sweden, but I shouldn't. I think that that there are many countries who are doing a lot of good things when it comes to this. I think that the Nordic countries are actually have quite advanced solutions when it comes to the national platforms. Estonia, for example, have a whole infrastructure set up for everything digital for their. I'm a little bit, there are some drawbacks in their solution as well. When it comes to, for example, you don't have immediate access to your full record, but a summary when uploaded by your clinicians, which I don't think is the right way to go. Finland is doing really interesting things when it comes to the national data layer, and being able to, for example, donate data to research and give consent to have your records available for research. And so I think that there are, depending on how you look, different countries have solved things differently. So I'm not sure I'm going to point out.
Do you get a sense that even if no one's doing it perfectly, most of the problems have been solved somehow by someone somewhere? So that if you strapped all the good best practice together, you could come to something that's nearly there, wherever there is.
Probably when it comes to having access, we can find. But when it comes to the things that Kajsa was saying, we're looking ahead now and looking at patients' input to the records. I don't think we see any really good solutions. We've had the ability to comment in the Swedish records, but it's being removed now in the new version, which is a highly disappointing move.
Wow, that was something that came up very strongly in the first webinar on ethics, was the ability to interact with and have your errors corrected. One of the things that came up in the second webinar was the anxieties, particularly on the part of clinicians, about being overwhelmed with requests to correct records. So it's interesting to hear that that's being taken away. John, do you, from a technical point of view and from an NHSX point of view, in terms of the ability to correct errors, is that something you're looking into? And you mentioned with the About Me section of your proof of concept, where are we at with that?
Well, on the About Me bit, as far as the international patient summary is concerned, it wasn't intended that would be used to correct errors. I mean, I was very taken by that thing on the first seminar, which I think it was something like 2 out of 25 errors identified by patients were medication errors. You know, that's a life and death issue if we don't get that right. And I thought that was really insightful. And I've used that in conversations since, trying to say, look, we need to think how we deal with this. And I completely understand the professional's concern, you know, how am I going to get all this right? But I've had to write a number of reports for the Secretary of State in response to coroner's reports, where the coroner has concluded that the failure to share information may have had a contributing factor to a death. And I don't want to do that anymore, because it's really, you know, it's a never event in our health informatics world. We should never be in a situation where that happens. So I think the need to have as many mechanisms as we can to correct, and of course there's a sensitivity here. You know, it may be an opinion as opposed to a factual correction, and there may be some tension in that respect, but nevertheless there are things which I think can be pointed out as factually incorrect, and we do need to make sure that they are put right. So I don't have an answer, but I was very heavily influenced by what I heard.
Kajsa, would you like to come in on that at all?
Sorry, I muted myself. I think that's actually really, really important. That almost then also brings us to situating this whole thing within the whole quality improvement and patient safety improvement efforts. Basically, you know, patients' access and being able to also contribute your own health data is a patient safety issue.
Zoe, in terms of patients' access to correct errors on their notes, is that something you've dealt with in your setup?
I mean, so not directly, but just with regard to the patient safety aspect that Kajsa brought up, it is really relevant. I mean, just a very simple example within sexual health is that our patients in real time receive their results from the tests that they can order through our online and interactive system. Means that they are aware of, let's say, an infection that they have before we're aware of it. It's there on our, but before our systems are in place to get in touch with them and inform them. So from a public health perspective, just having that information out there for the patient to access in real time has a knock-on effect for the individual, but also from a public health perspective. And I think what we've realized is that with patients having access to that information, there was originally a concern, well, I don't want patients accessing the results before the clinician has had a chance to have a look at them. And again, we've discussed that before, but in actual fact, it changes how you work. You don't do tests on individuals or order investigations unless they're prepared to receive whatever the result might be. And so actually, instead of ordering tests and then having a conversation with your patient when the results are back, what you're doing is you're having these educative, informative conversations where you agree on a choice of investigation with the individual, knowing full well that they are prepared to receive whatever result comes through. So I just think from a safety perspective, from a governance, from a public health perspective, you know, that this conversation, we don't need to be having it anymore. I think it'd be nice to see the data. I'm not quite sure how we collect it, because anecdotally we know it's happening where we're using these systems. But again, to see how that could be collected in a way that would make the argument, so that we don't need to be having these conversations anymore, because it's just a given that it's a good thing to do.
I think that's something that has come out to me from across all of these webinars, is that the case for this is it's pretty much unarguable now. It's just a question of how. And I think to conclude, because we're pretty much out of time now, but just to quickly go around the panel, where's the advocacy going to come from to get this done? Where is it? From the patient community? Is it the clinical community? Is it from the top? Is it from the bottom? Zoe, given that you had the mic, where do you see this being driven from here onwards?
So I think it would probably have the most impact if it was driven from the service user perspective, would be my view. I think when people start to request it, when people start to demand it, when people want it, then I think it's really difficult, because it's very difficult to deny anybody this, because there isn't a reason for doing so. So for me, I think that the groundswell is where it needs to come from. I think that would be most effective.
Kaiser, I'm going to come to you last on this one, because I think that's where we want to end. But I think Maria, in terms of the grounds, where do you see the groundswell in a similar way to Zoe?
I hope so. I hope that this is where the advocacy will come from, but I also think that it needs to be met with advocacy from other parts of both the sort of technical people, the people working with standardization and infrastructure. There needs to be an interest to actually meet the demand from patients. And I also think that there needs to be professional champions as well, in order for the sort of the expressed demand from patients to be met. Because otherwise it's, I think it will have to come from several sources for it to be successful.
And John, who would you like to be advocating for this stuff to make your life in delivering and designing it easier?
I want patients knocking on the door. I want them demanding this and saying, this will not only make my life easier, and not mine, but the patient's life easier, but it'll make the whole patient-professional relationship much more constructive, I think. They will be truly partners in their care. So patients.
Kaiser, I'll leave you with the last word on this. Are patients knocking on the door yet? And how do we, if they are not, how do we light that fire?
I think they are. Of course, I'm only here on behalf of one patient organization. I know there are many of us. I do see that this is where the change has to become and has to be coming, and patients are now pushing for this. Also because we are seeing things happening that we couldn't have thought of some years ago. It's possible, so what's the excuse for not doing it? But I also agree with Maria that we need partners, we need allies. So it needs to be a community of people and of organizations. And I said before, maybe a combination of sort of bottom-up movement and change, supported by an enabling environment from the top. For example, if you frame it explicitly as a right, if you have the right legislation in place, then that's going to be very supportive. EPF will be working on this also a bit more explicitly by putting out some statements in the next months, and we hope to maybe share them with you when we're done.
Fantastic. I think that's a wonderful place where to end this webinar and to end the series. Thank you so much to all the panelists for this webinar, for the three preceding it. Thank you everyone for joining. As I said at the beginning, the recordings will be available on the BMJ YouTube channel. There's been some discussion on Twitter. We will be looking into following all of this up with articles in the BMJ to keep this discussion going. There is a section on the BMJ website. If you look under I can't remember where it is now, it's the patient access to health records in the collections part of the BMJ website. There's already a wealth of content there, and we're hoping there'll be much more there in the months to come. thank you once again to everyone. Thank you to the team at the BMJ who've helped make all this possible, particularly to my co-host with all of this, Emma Doble. And thank you to you all for your contributions and for making this a really stimulating and excellent series of webinars. I hope you've enjoyed it. Thank you very much.
Thank you, Henry.
Thank you.
Thank you. It's been fun.